Hey guys, welcome to my channel. My name is April. If you're new here, be sure to hit that subscribe button so that the next time I post content, you'll get notified. Today, we are going to talk about trends in maternal health care. And if you want to learn a little bit more about me, you can read about me in the description below. So today, let's talk about some contemporary or current trends that are going on in maternal health care. To begin with, the definition of maternity nursing is going to be the care of childbearing women and their families through all stages of pregnancy and childbirth and for the first 6 weeks after birth. So it's a really long span of time that encompasses the definition maternity nursing. So let's start out our discussion with what are some problems in the United States healthcare system. And I'm sure that on this list, none of this is a surprise to you. Our healthcare system is definitely not perfect. We suffer from fragmentation. Our system for many clients is exceedingly expensive. And for many of our clients, it's also difficult to access. Some of our clients have limited access to care, not only because maybe they don't have health insurance or they can't pay, but maybe they don't have transportation. And so they can't get to a provider. Maybe they don't have anyone to keep their children that are at home. So therefore, they don't feel that they can take all of their young or small children on maybe public transportation to get to their doctor's visit. And then other clients may struggle with finding providers who accept their form of payment. For example, if a client has Medicaid as a form of payment, maybe they don't have a provider in their area that will accept that form of payment. Of course, when we talk about maternity health care, sexually transmitted infections are a big problem in this country, as are a lack of reproductive health services for adolescents. And then, no surprise, our system is fraught with medical errors. Moving into Healthy People 2030. So we just finished our Healthy People 2020 initiative. And I would really encourage you, especially if you're taking an OB course this semester, to go take a look at Healthy People 2020 and a lot of those initiatives. I think there's more than 30 initiatives that relate to maternity and pediatrics. To go take a look at some of those initiatives, maybe that you have some interest in, and take a look at where we started with that initiative back in 2010, all of the work that was done, and did we actually meet the goal by the year 2030? Now, for many of those, we will have met the goal, but for a lot of them, we will not have met the goal. And many of them then rolled into 2030 Healthy People with new goals. And some of them, of course, were retired, but many of them rolled over just with new goals and fresh initiatives. So when we talk about Healthy People, the initiative itself focuses on changing patterns of behavior so that we have healthier clients, healthier families, and healthier communities. So we're not, in Healthy People, in the Healthy People initiative, we are not trying to cure disease. What we're doing is health promotion. And along with that, we're doing health education. And we're trying to really take patient by patient, family by family, community by community, and spread wellness across this country. Like I said previously, there are a lot of objectives related to maternal care, infant care, and child health. So I would really encourage you to go back and look at Healthy People 2020, but really to take a look at Healthy People 2030, because that is the initiative in which you are going to graduate from nursing school and become a registered nurse practitioner. And those will be the initiatives that you will be helping patients to achieve in your communities. So when we talk about major health risks that are addressed in Healthy People 2030, hypertension and heart disease are always big focuses. Diabetes, depression, intimate partner violence. Now that's a big one for maternity care. Genetic conditions, sexually transmitted infections, tobacco, alcohol, and substance use, inadequate nutrition, and then people of an unhealthy weight, whether that's underweight or, unfortunately in this country, more often than not, it's overweight or obese. I do have a link to the Healthy People 2030 initiative at the bottom of the screen. The website did change from Healthy People 2020, although you can still access all of the 2020 data. You'll just need to do a browser search and you'll be able to find that website as well. Other things about Healthy People 2030, remember that lots of factors affect pregnancy, thus they affect childbirth outcomes. So first and foremost, preconception health status. So, was your mother healthy when she got pregnant? And when we say healthy, was she free of acute and chronic conditions? And was she of a healthy weight? Was she consuming things, whether it was unhealthy nutrition-related substances or alcohol, tobacco, or illicit substances before she became pregnant? So preconception health status really plays a huge role in the outcomes for both mom and fetus. Maternal age. So we do consider advanced maternal age to be age 35. Risk factors for things, especially genetic conditions, Down syndrome comes to mind as a really prominent one, significantly increase after age 35. Now, that's not to say that women aren't having babies later and later and later in life, and many of them are having very successful, healthy pregnancies, but in the maternity world, we do consider any mom who is age 35 or older to be in a more high-risk category. Access to care, we've already talked about. Prenatal care is so important. Regardless of whether you're 25 or 40, prenatal care really is the key, or the key to a healthy mom and ultimately infant that is going to be born. And then poverty. Your disparate populations, such as those that are homeless, living in poverty, really suffering from socioeconomic issues. Those things are always going to affect your pregnancy and possibly your childbirth outcomes. So those are all things that will be part of your initial health assessment when you do an intake for prenatal care, and things that you really do want to consider and address. So factors affecting the infant and ultimately the child, the fetus and the infant directly, family income. Family income really does affect the pregnancy, but then once that infant is born, we know that infants that are born into low-income families have a higher rate of SID, sudden infant death syndrome. Breastfeeding. Breastfeeding really impacts the health of your fetus. Lots and lots of research that proves that. And as you get further into your OB course and you start to talk more about breastfeeding, you'll get into all of the true, very, very evidence-based benefits to breastfeeding. And then, of course, the physical and mental health of your parents plays a huge role in the health of your infant and ultimately your child as they get older. Racial and ethnic disparities. We do know that women of African American descent tend to suffer higher rates of preterm delivery, higher rates of hypertension, preeclampsia. So you definitely do have some risk based on racial and ethnic populations. How are we going to mitigate those risks? So first and foremost, we want to improve access to quality care. And we really want that to start before the pregnancy. If at all possible, we want women to be at their optimal health. And of course, that varies patient to patient, but at their optimal health before they become pregnant. Then we want really high quality prenatal care during pregnancy. So we want to make sure that women can access that. Maybe it needs to be through your health department as opposed to a private physician, but there are lots of levels within our healthcare system for women to access quality prenatal care. And then we also want women to be getting good care, quality care in between their pregnancies. So once they've had that baby, we want good follow-up after in that postpartum period. And then as women, we want to maintain that health so that the next time that mom becomes pregnant, she's in an optimal state for that next pregnancy. And then the second thing that we really want to do to mitigate risk is we want to identify any problems very, very, very early. And that goes hand in hand with that high quality prenatal care. So, ultrasounds and blood work and frequent visits to a provider to identify, any concerns that we have with this pregnancy, whether it's preeclampsia or gestational diabetes, or it's a chronic or an acute illness that is affecting the pregnancy. We want to really do a good job managing those problems throughout the pregnancy. So again, we can optimize that mother's health, which is going to in turn optimize the health of that fetus and ultimately the infant that's born. Once that baby's born, we really want to, again, early identify any developmental delays or disabilities in that infant. So that, that high quality care needs to continue after that baby is born for not only for the mother, but also for that infant. There are some emerging issues that we deal with in this country that as OB providers, OB nurses, maternity nurses, we do really want to kind of keep to the forefront. It's a lot of research is going on, a lot of health initiatives related to these emerging issues. So the first one is unplanned pregnancy. And remember, back when we first started, I talked about how one of the problems in this country is lack of reproductive prevention services for adolescents. And that really does contribute to unplanned pregnancy. But also, you might have a woman in her 20s that doesn't have any health insurance or doesn't have access to a provider and can't afford or doesn't even know how to prevent pregnancy. So unplanned pregnancy, big problem. When women become pregnant, regardless of their age, when it is unplanned, you often see delayed initiation of prenatal care. Not always, but often you do get a delay. And so remember, think back to everything we've talked about and how important it is that we start seeing that mom from the very beginning. That first prenatal visit really should be between 6 and 8 weeks. And so when you have that delayed initiation of care, it really can create some problems for both your mom and then ultimately your baby. Poor maternal health. In this country, we have a lot of obesity. We have a lot of acute and chronic illness just in our population in general. Well, all of those problems are going to compound a pregnancy. And they're going to manifest as now pregnancy problems. So maternal health, really important. And then of course, both poor maternal health, delayed initiation of care, be it related to that unplanned pregnancy or not, can often result in a preterm delivery. We really don't want babies delivering prematurely. And you'll hear much more about this when you get into your newborn section of the course during the semester, but preterm babies are at significant risk of lots of different problems. Kind of irregardless of whether they're born at 28 weeks or whether they're born at 34 weeks. The severity or the types of problems differ to some degree, but there's always that increased risk. So we really want moms to go that full 40 weeks or really to make it to that full-term status before they deliver. And then, of course, infertility. We see lots and lots and increasing numbers of infertility in this country. And a lot of that is related to that poor management, patient compliance with acute and chronic problems. That definitely contributes to the inability to become pregnant. Other contemporary issues in maternity healthcare have to do with nurse staffing and patient ratios. So probably no surprise there. Those are problems in all areas of nursing. But today, of course, we're talking about maternity nursing, but those problems plague this specialty as well. So because, again, our population in a lot of parts of this country does tend to be a more unhealthy population, that makes patient complexity a lot higher. So patients are coming into the hospital with antepartum problems or intrapartum problems, or they deliver babies that then have neonatal problems. So the complexity of care, the acuity of those patients and the stability is a lot higher. the number of admissions, discharges, and transfers, especially in really busy places where they're, they're getting lots of admissions and lots of turnover of patients, and maybe they don't have adequate numbers of staffing or nurse staffing. Really do contribute to problems. Professional nursing and other staff skill level and expertise. So maybe you have plenty of staff on your shift to handle the patient load, but maybe the majority of that staff is inexperienced, with less than maybe a year of experience. Again, that contributes to poor patient outcomes. Maybe you have, the wrong skill mix. So maybe you have just one or two RNs, and then maybe you have a large component of help that is your practical nursing staff or unlicensed assistive personnel. Again, contributing to problems. Other issues that we see in healthcare, particularly, and not just particularly related to maternity care, but is physical space and the layout of your nursing unit. So are you able to keep your higher risk patients closer to your nursing unit? Do you really have the time based on your load and your skill mix and the number of staff that you have to check on those patients frequently and to have access to those patients very timely and efficiently? And then, of course, the availability of technical support and other resources. Are you constantly fighting with your electronic medical record because it's not wanting to work? Are you constantly having to be on the phone with support staff, or trying to get resources up to your unit that you need in order to care for patients, but you can't get them or don't have them? So all of those contribute to poor patient outcomes. Now, the Association of Women's Health, Obstetrics, and Neonatal Nurses is the professional organization for maternity nurses, and they have actually produced guidelines for nurse staffing for perinatal units. Now, it's not mandated, of course, by state law. Most states, in fact, don't have mandated nurse-patient ratios. Now, some do, but most don't. But what AWHONN puts out is a guideline. So basically, they say that based on the type of patient that you're caring for, whether they're intrapartum, uncomplicated, intrapartum, complicated, postpartum, uncomplicated, complicated, antepartum, same thing. How many patients one nurse should be taking care of. Really, really interesting document. You can put it into your browser, search. This is the exact name of the document, and it is readily available. So really interesting to look at what your specialty organizations say about minimum staffing, and then compare it to maybe what you are seeing in the hospital when you go to clinical. Okay, AWHONN itself, again, great specialty organization for maternity nursing. So their vision is to make a difference in the lives of women and newborns, and their mission is to empower and support nurses caring for women, newborns, and their families through research, education, and advocacy. So when we talk about kind of your standard of care for these specialty areas, you're going to be held, of course, to your scope of practice, or your state board scope of practice. But when you work in these specialty areas, you also are held to the standard of your specialty organization. And AWHONN puts out a lot of practice guidelines that are very specific to maternity nursing. So for example, they have practice guidelines on using emergency contraception. They have practice guidelines on the bedside registered nurse managing a patient-controlled epidural anesthesia machine, or the process of patient-controlled epidural analgesia. They have practice statements on managing the second stage of labor. This is all from a nursing perspective, evidence-based research. So when we talk about evidence-based practice, and nurses, especially new nurses, go out into the world and they're like, well, how do I stay current? How do I know what's changed? Well, being a member of a specialty organization is a really great way to stay current on what's changing and what you might want to advocate for or adopt into your personal practice. Okay, the next couple of slides just have some definitions on them. I won't read them to you for the sake of time, but just know that these are definitions that you do hear in this maternity world that you're now immersed in. So fertility rate, birth rate, mortality rates, whether it's infant, neonatal, or maternal. So just make sure that you're familiar with, when you see those words, what that actually means. On the other hand, on the other slide, pregnancy-related deaths, abortus, stillbirth. So some really commonly used definitions that you need to be familiar with. Now, I did go back and look at our most recent data, and this does come from the CDC. This is the final data for 2018. So, you know, when we look at our data for our country as a whole, we do tend to be several years behind in those publications. So this is the final data for 2018. It was published in 2019. So our birth rate was 11.6 per 1,000. And actually, if we go back to birth rate, we'll see that that's the number of live births in 1 year per 1,000 people. So that's your birth rate for 2018. Fertility rate, 59.1 births per 1,000 women. Percent born low birth weight is 8.3. And our 2020 Healthy People Initiative goal was 7.8. So we didn't quite make that goal. We got closer, but we didn't meet that goal. The percent of infants born preterm, 10%. Our target was 9.4. So again, we've gotten better over the last several years, but we're still not hitting the target. And then the mean age at first birth, 26.9 years. And if you go back and look at data from the earlier parts of the 2000s, you'll see that the mean age at first birth is definitely getting older. Now, when you start to break that down by region of the country, you see less variation. But when we look at the country as a whole, that birth rate, that age of first birth is definitely climbing. If you would like to access this document where this data is pulled from, the link is down here at the bottom of the slide. Other trends in perinatal data, this is actually the final data for 2017, again, published in 2019, but they didn't have it available yet for 2018. And so this is about our infants. So our infant mortality rate, 5.79 per 1,000, our goal is 6. So again, getting closer, or actually we're exceeding the goal for infant mortality rate just by a tiny bit, but we are exceeding the target. Leading causes, again, this is data from 2017, but leading causes in 2017, the #1 leading cause of infant death. And if we go back to our definitions, infant mortality rate is the number of infants that die within 1 year of birth per 1,000 live births. So within that first year. Congenital malformations is #1. So these are babies that are born with some kind of genetic defect. It might be a heart defect, it might be a gastrointestinal defect. Any kind of genetic malformation is the #1 leading cause of death, followed by disorders related to preterm birth. Now, remember, we talked on a couple of slides back about how important it was for, babies to stay inside that mom for that full, 40 weeks, because second leading cause of death, premature birth. And then followed #3, newborns affected by a maternal complication, such as those acute or chronic conditions that moms come into the pregnancy with, or a condition caused by pregnancy that mom acquires, such as preeclampsia or gestational diabetes. #4 being sudden infant death syndrome, and #5 being an accidental death, such as a motor vehicle accident, drowning, something of that nature. Again, if you would like to access this data or have more information, here's the link to the document below. Okay, let's talk about obesity. No surprise that the most recent data is 2016 from, this is Healthy People 2020 and for data. So again, a link to the data is listed below. But in 2016, only 48% of women had a normal weight when they got pregnant. So that would be a BMI between 18.5 and 24.9. That means that more than 50% of moms who got pregnant in 2016 were either underweight or probably more likely overweight or obese. The target is that 57.8% of moms have a normal weight before they get pregnant. So we're very significantly off on that target. And probably for many of you, that's not surprising. But that really is a big focus of Healthy People 2030. And if you want to take a look at what the targets are for 2030 and what some of those initiatives are, you can go back to that Healthy People 2030 website. So when we talk about why this even matters, why do we care that women have a normal weight prior to pregnancy? It's because being overweight as a pregnant woman or obese contribute to some significant pregnancy complications. The first one is preeclampsia. That is high blood pressure with other problems that it causes. So it's not just high blood pressure, it causes other problems that develops during the pregnancy. So we're not talking about women who had high blood pressure before they got pregnant. These are women with high blood pressure that develops during pregnancy. Gestational diabetes. So again, this is women diagnosed with diabetes in pregnancy. Being obese contributes to stillbirth. That's a baby that is born not alive. And it also significantly contributes to needing a cesarean delivery or a C-section. We do know that C-section is major surgery. So therefore, the morbidity and mortality associated with a C-section compared to a vaginal delivery is significantly higher. Other trends, telehealth. We've seen a lot of telehealth this year because of COVID-19 and all of our shutdowns. But even before COVID, we were starting to see a lot of telehealth. Now, it wasn't always patients that were getting screened over in virtual ways, but we were definitely having providers consulting over virtual. Now, sometimes there was a camera in front of the patient and a remote doctor was assessing that patient, but we've definitely seen an increase in telehealth. Social media. Social media is a big benefit, but also problem that we deal with in all forms of healthcare. One of the good things about social media is everybody, for the most part, not everybody, but most people are connected to some form of social media. So it's a really good source of information for a lot of women. But what we also know is that oftentimes, or a lot of times, that information that mom is accessing is not necessarily accurate. So there lies the good and the bad. We won't have a discussion right this second about how dangerous social media can be for you as a healthcare provider, but hopefully somewhere in your nursing program, you're going to hear about that and learn how to avoid some of those pitfalls for you as a professional. Community-based care. So we're seeing a lot of community clinics pop up. A lot of them are grant funded by the state. Some of them are grant funded by governments. Some of them are grant funded by private sources. So again, remember we said access to care is a problem for a lot of women, especially in rural areas or in very poor communities. And so community-based care, because it's grant funded, means that women can come and seek care. And remember, we're talking about prenatal care, but you'll see community-based care across all specialties. But these women who are pregnant can come and seek this community-based care at very low to no cost. So that's a big trend that we've been seeing. Physicians versus midwives. This trend is not necessarily new, but we definitely are seeing it very prevalently, more and more. So women often do have the opportunity to choose. Do I want to see, a physician for my prenatal care and my delivery of my child, or would I like to see a midwife? Now, when we think about midwives, the other thing to consider is that there are lay midwives in a lot of parts of the country, probably all parts of the country, who only have hands-on training. They don't have any education or certification. And then we have nurse midwives. And in the hospital setting, what you're going to encounter is a nurse midwife. But you do have people delivering at home in parts of this country with a lay midwife. You know, is that a dangerous situation? I think that's a, you know, a real ethical dilemma that you can debate. You know, technology definitely enhances childbirth. We can see problems much quicker. We can act on those problems much quicker. But there is a lot of research and data out there that shows that technology also sometimes makes us rush to decisions like C-section or early delivery, when perhaps we wouldn't have rushed to those decisions if we didn't have this excessive use of technology. So definitely pros and cons. When you think about the just kind of overarching difference between a physician and a midwife, it does tend to be that lack of, and I don't want to use the word technology, because a lot of midwives do deliver in hospitals and they do use technology, but less intervention, I guess, is a good word. Not that all physicians are high intervention deliveries, because I've worked with many physicians who also subscribe to very low intervention delivery for low risk women. But it is the difference between a medical model and a nursing model. And so just depending on, you know, what type of experience the mom wants to have, she will choose either a physician or a midwife. Doulas are another trend that we have really been seeing for quite a while in maternity, although again, gaining in popularity as women want more and more low intervention deliveries. Doulas can be certified, you know, or they have a certification that they can attest that they can take. They can also be trained from an education perspective, but a lot of them are lay people as well. Some hospitals do allow doulas to come into their facility. They offer and maybe even employ doulas who are available to patients. But most of the time, doulas are employed by the mother, the family. And that doula is contracted with and paid in whatever form, you know, that doula contracts with that mom, comes into the hospital and provides emotional and physical support. Now they can't provide nursing care. You still, you know, you're still in the hospital. Your nurse is providing all of that scope of practice that we as nurses have to do. But that doula is really hands-on, providing that intense emotional support that a lot of women need to have, you know, a low intervention or even an unmedicated delivery. So that's another trend that we see in maternity. And here's just a little bit more about the doula. So again, they are often a paid caregiver. They often have a lot of experience. I've worked with some excellent doulas that have a lot of experience supporting women. Some receive special training, but not all. But basically their role is to advocate. They can be a great asset to you as the nurse. You know, you unfortunately as that nurse, you most likely aren't just caring for that one mom, and you can't be at the bedside all the time, but that doula can really provide that emotional support continuously at the bedside. So they are trained to provide labor support skills, techniques, strategies. They offer guidance and encouragement. They help to build a team relationship with the nursing staff. They encourage communication, and they assist mothers to cover gaps in their care. So they really help that mom advocate for the choices that she wants for her experience having this baby. Okay, moving on to evidence-based practice. This is not a new word. I'm sure you've heard this word before. This is the act of providing care, so our nursing professional care that is based on evidence gained through research and clinical trials. So when the decisions that we make about how we are going to care for patients should always be backed up by research. Now, what we know in medicine is that what we do today may be very different than what is recommended a year from now, or 2 years from now, or 6 months from now. So staying current on what is changing in evidence-based practice and recommendations and protocols is very important. So again, here's where your specialty organizations come into play. So we've already talked about A1. There is also a pediatric practice organization. Now there is one for nurses, but the American Academy of Pediatrics is for doctors, but it has a lot of great information for nurses and for parents. So a really great evidence-based site. And then ACOG is the American College for Obstetricians and Gynecologists. So it's the physician version of A1. A1 is nurses, ACOG is for the docs. But as a nurse, you can often access the practice protocols that come out from ACOG. And just like A1, they have lots of practice protocols that they recommend based on research and evidence for those doctors to care for women. Okay, the family. So remember, we are providing family-centered care as a model of care for maternity. So you don't just have the mom and her fetus as your patient, or the mom and the baby after delivery as your patient. You are caring for that entire family. And that family is whomever the mom says the family is. It might not be your traditional family structure, but we are caring for all of them. So our emphasis is on wellness. And we want to empower that family, empower that mom to care for that child once they go home. Clinical competence is always key. And remember that your family is the primary unit of socialization for that mother. And again, don't be fooled into thinking that it's going to look just like your family or just like that traditional family. It may be a very non-traditional unit of socialization that mom surrounds herself with. Again, family-centered care, it's a very, very common word that you hear in maternity nursing. This is a model of care. It's based on holistic care. So you're providing for physical needs, but also sociocultural, spiritual, and economic. Now, when we say economic needs that the nurse is providing for, a lot of times that comes in referrals or recommendations for resources. And those are considered and combined collectively when you care for this mom. And so great examples of family-centered care in maternity are your labor, delivery, and recovery rooms. So your mom labors, delivers, and recovers all in the same room. And, you know, very interesting, you know, 30 years ago, 20 years ago, we didn't have that. Some hospitals still don't have that. Moms are actually transferred to a delivery room and then transferred back out. But having that single room where everything happens is very much a family-centered care trend. Those rooms tend to look like hotel rooms. You've probably seen them, maybe even had a baby in one of them. And we do really encourage families such that the mom wants them to be around, to be present and active. An LDRP is a labor, delivery, recovery, and postpartum room, which means the mom never leaves the room. Now, some hospitals do separate out their delivery area from their postpartum floor. So you might deliver in an LDR and then transfer to a postpartum room. But smaller hospitals especially, you will never leave the room that you deliver your baby in. And then similar, you might hear the word single room maternity care. It's the same as an LDRP, but you might hear it called a single room maternity care. Okay, I always like to talk just a minute about ethnocentrism versus cultural relativism. We see this a lot in nursing in general, but I really like to talk about it when we talk about maternity. So you've heard me say a little bit already that it's the mom's experience. It's whatever the experience the mom wants. And again, that's within reason, right? You know, if your mom has, you know, a really acute problem and doesn't want to have a C-section, sometimes that's not an option. But especially with moms who have low risk pregnancies, this is their experience. It's not our experience as the nurse, it's their experience. So let's talk about ethnocentrism. Ethnocentrism is the view that one's own way of doing things is best. And when you read that, you're like, oh, that sounds great. You know, you might hear the nurse say, I want to treat everybody the way I want to be treated. And in your mind, you're like, awesome, that is exactly what I want to do. But the reality is, you know, I'm, you know, a Caucasian woman raised in the South in America. women who are of different cultures, ethnicities, and or just from other parts of this country may not want to be treated the way that I want to be treated. So ethnocentrism is really not what we want. We also sometimes see nurses who think that they know best. Now, certainly we have training and we have a lot of education to back the things that we advocate for. But we definitely can sometimes see nurses who think the only way to have a baby is with continuous fetal monitoring. But the reality is even AWHONN and ACOG recommend that if you have women with low risk pregnancies, they don't need continuous fetal monitoring. Now, if you have a mom who needs oxytocin to induce her labor, or she has preeclampsia or any kind of a chronic or acute problem, she definitely needs continuous monitoring. But again, don't get hung up in thinking that your way is the best way, or I had my baby this way, or my best friends had their baby this way. I know what's best. It is not our experience. It is the mom's experience. I think it's also important to remember that for most women, pregnancy and delivery is a state of wellness. It's not a state of illness. Cultural relativism is the opposite of ethnocentrism. This is where we learn about others' cultures, others' beliefs, others' values. We learn what that mom wants, and we incorporate that into our plan of care such that we're able. Now, are we always able to incorporate everything that a mom wants? Most likely not. But we can definitely make a great effort to incorporate beliefs, values, cultures, preferences, choices, especially in these low-risk pregnancies, but even to some degree in high-risk pregnancies, based on what that mom wants for her experience. So remember that our culture does determine our viewpoint. Women who come in to deliver a baby, especially who are of a different culture possibly than you are, may have a very different view of what childbirth is supposed to look like than you have. It doesn't make them wrong. It doesn't make you wrong, but it is her experience. We don't have to accept the beliefs and values of other cultures. We don't have to agree with them. We don't have to subscribe to them. We don't have to practice them. But we do have to recognize that they can be based on logic. It's just different logic than our own. And that just affirms the uniqueness and value of every culture. So cultural competence, big overarching term, but what we're really doing when we care for patients is we're trying to demonstrate cultural relativism. Okay, other strategies related to cultural competence: break down your language barriers. Most facilities will require you to use an interpreter or a language line, but it really does depend on the facility. Some will let you use a family member. Other facilities that I've been in say absolutely not, you cannot use a family member. So really understand what your facility allows, but do break that language barrier. I don't know if you've ever tried to care for a patient that you don't speak their language. It's very frustrating. It is very difficult when you can't communicate. I think we take for granted being able to communicate with our patients, and then we can't. And it does become very difficult. So break those language barriers. Get consent from the right person. And so that goes back to understanding the culture of the person that you're taking care of. Providing language appropriate materials. Asking that mom about her values and beliefs. And I'm going to show you some questions on the next slide that I like to use as I'm trying to assess what mom wants for her pregnancy or for her delivery. And then I think it's always important also to ask, especially a first-time mom, but all moms, what are they afraid of? What's your biggest fear? What could happen today that would just be your absolute biggest fear? Because a lot of times it's something simple that just you being aware of, you can make sure it doesn't happen. Like maybe the mom says, oh, I'm so afraid that I'm going to be left alone. Well, we might not can be at the bedside at all times, but we can work with the family and make sure that that mom is not left alone. Here are some questions. And I'm not going to read all of these to you, but these are just things that I like to assess upon intake of a woman who's in labor, just to kind of get an idea of what does she want that might be different than what I'm anticipating that I can build into my plan of care. So remember, nursing plans of care are patient-centered, and this is the true definition of patient-centered. It means that I don't build the plan of care by myself. I work with the mom and with her family, and we collaborate on what this plan of care is going to look like. Now, there may be some things that are non-negotiable. For example, I've worked in places where the laboring mom had to have an IV. You would have moms that would come in and say, I don't want to have an IV. But our facility, that facility required an IV. So there are some things that are non-negotiable, but there are a lot of things that aren't non-negotiable that we can work with this mom to enhance her experience. And then these are just some key culture terms that you're going to want to be aware of as you learn more about trends in maternity nursing. Okay, if you'd like a little bit more information or help studying for this OB class, many of you, I'm sure, are very aware with registered nurse RN. She does a great job on a video titled How to Study for Maternity Nursing. It's a little bit on the long side, so it's almost 13 minutes, but it does have some really excellent information. So I highly recommend that video. And again, I will have that linked in the description below so that you can just click on it and it will take you straight to that video if you would like to view it. And then, of course, if you have any questions about this content, please feel free to reach out to me. You can leave a comment down below and I'll be happy to answer your questions there, or you can contact me either via email or on my Twitter account. So that's it for Maternity Trends. Have an awesome day. See you later.